Hello again, welcome back. Delighted to have you join us again for our series of podcasts that we call Menninger Mindscape. I have a very special guest today, Dr. John Greden. John, great to have you here.
It's great to be here.
Good. To Houston from Michigan. And Dr. Greden is a good friend and colleague and is the director of the National Network of Depression Centers. I want to say a little bit more about that in a minute, and he'll tell us about it. But he's also, before that, was chairman of the Department of Psychiatry at the University of Michigan in Ann Arbor and founder of the initial Comprehensive Cancer Center of this network, which is the one he continues to direct in Ann Arbor.
I'd like to say I founded the Cancer Center, but you really meant
Did I say Cancer Center? Well, it's Depression Center.
Yes.
But it's founded and modeled on
Absolutely.
the Cancer Center network, and that's where my slip came from. So you'll tell us more about that, because actually that is something I was going to bring up and ask you about. But let me tell you a word or two about other credentials of Dr. Greden. He is the Rachel Upjohn Professor of Psychiatry and Clinical Neurosciences in the Department of Psychiatry at the University of Michigan in Ann Arbor, but also a research professor in the Molecular and Behavioral Neuroscience Institute. And then, as I said, the founding chair of the National Network of Depression Centers. So I'm going to turn it to John and ask him to tell us about that, but just to add that we are delighted at the Menninger Clinic and Baylor Psychiatry Department to be the newest member of the National Network and are getting up to speed, and it's something that we're very, very proud to be part of. Tell us about it, John.
Well, John, the pattern that we have to address is the fact that for years we've been recognizing that we have an awful lot of depression, 1 of every 6 of us. We basically know that these things start young, that they, untreated, tend to just wreak havoc and have huge burdens and often become chronic in lifetime, and that our treatments don't work for everybody, and along the way we have done things on a short scale. And once, long ago, when I was on the executive committee of our cancer center at Michigan,
The real cancer center.
our real cancer center, I found myself being amazed. I was editing a journal, and I would look at potential articles that would come in, and they would have 28 people and 26 controls. And I would go to the cancer center meetings, and they would have groups presenting their database from 10,000. And the reason was they were doing it from a collaborative arrangement that involved many, many places, all parts of the National Cancer Institute network of centers.
A lot of difference in power of the data.
And in the longitudinal monitoring and the ability to sort of say, how do you get people well and keep them well? They measure outcome in 5-year survival. We measure 12 weeks, and it doesn't cut it. So the goal was at one point to say, and there was a long personal history from someone who had a family issue, and they said, why aren't there centers of excellence for depression and bipolar illnesses like there are for cancers? And we set out to start one, and that was approved by the regents at Michigan in 2001. But as part of the original mission, I had already decided that in addition to finding these things earlier and treating them better and maintaining wellness and counteracting stigma, we really needed to do something to try to copy what cancer had done and form a network. And so that actually was the concept. We didn't get going until about 2008, 2009. And then a group of us started to talk, and we're still growing, and it's wonderful to have Menninger and Baylor involved because you guys have real strengths in these areas. And collectively, we can bring expertise together, we can have large data sets, we can learn what works best, and we can respond to things quickly.
Yeah. Well, you know, you've heard me describe one of our research projects here, which is a data collecting project that's based on some outcomes data that we've been doing for many years. But now we're adding on to that with brain imaging studies, and we hope soon we've got samples are stored to be able to do some genomic studies as well. The centers in the network are encouraged to pool data, and you've set up a registry. We hear a lot about that, so I'm not sure everybody's familiar with that concept of a registry. So maybe explain that a little.
Okay. So I can't be critical because I've lived my life doing that. You have too. When NIH puts out grant requests, they put out a concept that they think is promising, and people who get it start collecting patients and creating the work and spending the money, and then they'll have several years, and then they'll end a study. Registries are a way of collecting people who have ongoing problems and who say, I'd like to be part of solving this problem. And I'm here, and if you need me for a future study, so an army of women for breast cancer, good example. And when you have 1 million women who are available throughout various parts of the country who say, count me in for some future studies, I need to consent, of course, but when that happens, you suddenly have right away much more readiness to move on.
Oh, that's a critical part of it, isn't it? It's not just that you have big numbers for a question you're asking now, but you have people willing to be available longitudinally over time.
And that's crucial because what happens is, first we need the larger numbers and standardization and the statistical power to answer the questions we have, because when we're in that brain and in events and environmental stresses, the pieces of information that we have to collect to understand all of the things that involve mental illness are huge, huge.
Yeah.
And so what we've got to do is to change our paradigm. The other approach hasn't worked, and we haven't made the progress that cancers have made, where they've blown some of those out of the water, pediatric leukemia, and we haven't made the progress that heart disease has made, and or even some of the other diabetes. And we've got to emulate, I think, what they're doing. And so that was the concept of the National Network of Depression Centers. The sharing of the data is a major strategy, but it's also sharing of the intellectual horsepower, if you will.
Right.
And so what you bring here, you've got people doing neuroimaging, you've got people doing actually some of the hot news stuff, I mean the ketamine infusions and other things. And I think that what we want to do is to have an ability to collect a large enough pool of information and to follow them longitudinally so that 5 years from now we can say, we know that this works. Not just an article, a publication, but we know that it works, and then we can refine it and keep improving it.
Well, sort of part of the goal is sort of parallels what's happened in cancer as well, which is to advocate for the better understanding of the illness of depression, of the problem of suicide, which we're going to be talking about tomorrow, and to really help people get past the stigma that used to be very strong in cancer years ago. But now it's not. I saw a billboard, I forget where it was, I think it was in LA, great big giant one, and I think you may have also mentioned it, which says, you know, imagine how you'd feel if you were told you caused your cancer. Because that's what people say about depression. Well, just snap out of it, get a life, stop whining, as if you could do that and that it's your fault.
If I can, in this nice interview, I'll actually see if I can briefly tell you a story. When the family that met with me to talk about starting our depression center at Michigan did it, this was Heinz and Wally Prechter. They're very open and they support one of the programs in bipolar illnesses. And when I finished my proposal, I presented it, and Mr. Prechter said, I love this, I just love this. But there's one thing that bothers me. Do you have to call it a depression center? That's so depressing. It's going to scare people away. And I responded by telling a story directly linked with what you just referenced. Both of my parents died of cancer, and my mother.
So did my father.
Yeah, and my mother was a head nurse when I was a medical student, and I can remember her telling me the news in the living room of my home that I had gone down to in Minnesota, and then whispering, "Now don't tell anybody."
Yes. Right.
And that was when we called it the Big C.
Yeah.
And I told Mr. Prechter this, and I said, we can get past that. There now are 32 comprehensive cancer centers, and there are lots more affiliated ones. We're going to do the same thing. And he said, he looked at me and he said, they still often do refer to it as the big C in Germany.
Interesting.
And I think what we recognize is you don't change stigma by changing names, by calling things wellness centers or whatever. We've got to have better outcomes. We've got to have honesty, education.
Boy, John, I couldn't agree more about that. I think that is so important. I mentioned my dad died of cancer, and he was told he had 6 months to live, and he lived for 5 years and worked for those 5 years and never told a soul because he was afraid he would be seen as dead man walking.
Or that it was contagious.
That it was contagious, that something was just, you stay away from that guy. But look how far they've come. Or we in the medicine have come.
Well, now they do cancer screening examinations on national television in the morning, and I think we're getting there, because I think when we did this, I said this may be the most important proposal, part of the proposal that I'm making, and we need to do this. And so we've watched and done some assessments now, and the students at the University of Michigan and others in the community gravitate to this now. They refer to it, and every summer we have a depression party. A depression, the community volunteers put on a party, and there are now 300 people that come and celebrate progress.
Yeah,
and,
well, I actually think you're right. I agree. It's coming, I guess, out of the closet a little bit, maybe more than a little bit, and making some progress. And I believe, actually, that it's things like the national network where you get a voice that becomes very public, and you've got some ambassadors for the importance of treatment.
You're one of them.
Well, but also former patients who've have the illness themselves, just like they're survivors of cancer who are out there making the pitch. And we have to keep doing that every way we can. But that's part of what the national network really has as one of its goals.
And I think if we talk about first, how do we make the difference in the diagnosis and earlier detection and screening and wellness and all of those really very important words, and then recognize that that's going to be very hard to do unless we counteract the stigma, inevitably, to really have the breakthroughs, if we are going to do things like having biomarkers, the lab tests, the genomics that you mentioned. Right. That's going to take us back to that need to collaborate and have the big data. Yep. And
well,
they all really fit together.
Yeah, and I am so happy that we're part of the network, and thank you for telling us a little bit about it. I can't wait to hear your presentation as well as all of the others tomorrow at the symposium, because you'll start us off by talking about the prevalence of the problem of suicide, and it is staggering, and the challenge is huge. So we will hear more about that tomorrow, but it's nice to have a little headline or two today. So thanks for joining us, and we'll look forward to what you're going to tell us tomorrow in more detail.
It's an honor to be here. Thank you.
And thank you very much once again for joining us, and see you next time.